Periodontally accelerated osteogenic orthodontics. Over the years, this has been described in various ways. Initially, the Wilco brothers, Tom and Bill Wilco, patented the term Wilcodontics, and this was patented in 1998. Subsequently, they changed their terminology and referred to this as Periodontally Accelerated Osteogenic Orthodontics, or PAOO, where it is commonly described now. However, Periodontally Accelerated Osteogenic Orthodontics does not exactly say what's being done. So in a variation on that, Colin Richman referred to this as pre-orthodontic periodontal augmentation, which I think actually describes what's being done, and he referred to this as PAPA. And whether you use PAPA or whether you use PAOO really makes no difference. And finally, Serge Debart has come up with a technique using a piezo incision. Periodontally accelerated osteogenic orthodontics. What is this? Orthodontics completed in 3 to 8 months. And as I said earlier, the classic article on this was published by the Wilco brothers in the International Journal of Periodontics and Restorative Dentistry in 2001. This is very significant in the adult patient who wants to have their treatment done often as rapidly as possible. Arches can be expanded without producing osseous dehiscences or fenestrations, which manifest itself as recession in the future. This increase in the bone mass allows for greater tooth movement in the adult patient where growth cannot be used to the advantage of the orthodontics in doing facial orthopedics. Continuing on the significance in the adult patient. Once the new bone recorticates, there is no bone memory. Now, why is that significant? For if there is no bone memory, there is less tendency for relapse, and obviously this makes for a more stable case. And because the movement is gentle, so to speak, and rapid, root resorption is not a concern. Now, let's focus on something, terminology that's very important. We're talking about superficial decortication. Rapid orthodontic movement occurs following selective superficial decortication of the alveolar cortical bone. I want to emphasize this is not a corticotomy. Let's continue on with superficial decortication. In thin bone, you want to make interdental grooves in the interdental area, and you want to connect these grooves apically. And here we see an example of the flap reflected and these grooves being made. Superficial decortication, what if you have thick bone? You make the same interdental grooves, you make the same grooves apically, but what you want to do is to make multiple perforations into the cortical plate. This allows for more blood flow to the bone graft, and here we see these little multiple perforations, and to highlight those where you can see them, we have animated those. RAP. RAP is a term that refers to regional accelerated phenomenon. This is the interval following decortication before the bone recorticates. This is the same phenomenon that occurs when a broken leg bone, say, heals. Typically, this lasts for about 8 months. After 8 months, further movement in orthodontic treatment is by conventional orthodontics at a slower pace. Let's talk about the classic surgical technique as offered by the Wilco brothers. Our patient that we see here is a 42-year-old female. Diagnosis and case description. We've got a class 3 malocclusion, full arch crossbite, small maxilla, and missing maxillary premolars that were extracted, hopefully to allow the arch to form naturally, but resulted in the class 3 malocclusion that we now see. We want to emphasize that no previous orthodontic treatment had been done. We see the occlusal view here, where the bicuspid is missing. The space has been completely filled, which has created the crossbite situation that we see on the right. And as we see the lateral view, the crossbite becomes very, very clear cut. Very importantly, the case needs to be bracketed pre-surgery. This can be done a week before, 2 days before, but the case does need to be bracketed, and the arch wire needs to be removed the day of the surgery. Full thickness flaps are reflected before decortication, and here we can see where the decortication was done and the vertical lines interdentally grooves have been created. The osseous graft is placed, and typically this is a combination of bovine bone and freeze-dried bone allograft. I would like for you to note the volume of bone that's placed, and now you can visualize how those teeth can be moved and not be moved out of bone. But speaking of that, now let's go post-operatively where a biopsy was done on tooth 11, and you can see the biopsy site, and below you can see that this is normal bone that has been regenerated, and this I think is 9 months after the bone graft was done and the case was completed. Here's a CBT scan showing preoperatively what the area looked like, and look at the great volume of bone that has been regenerated. Here we see a 1 month post-op. Tissue healing has taken well, and again you will note that no movement has taken place. As I said, typically no movement will take place in the first month. And this is what we talk about as the window of opportunity. 1 month after decortication, osteopenia occurs. This osteopenia allows for the rapid orthodontic movement, or the RAP. In 8 months, the bone begins to recorticate or remineralize, and any further orthodontic movement occurs at the rate of conventional orthodontics. This 6 to 8 month period of time is referred to as the window of opportunity for accelerated osteogenic orthodontics. Now let's move along at 2.5 months. We begin to see now a little movement has taken place on both sides, not markedly, but slightly. And we can see here where this space has opened up. Then we look at it 3.5 months and look at the difference in the size of the arrow, the movement that took place in that month from 2.5 to 3.5. And again at 4.5 months, and finally at 5.5 months, and at 7 months, and at 7 months of treatment, we can see that there is almost room now to place a single tooth implant on either side. And if we look at it from the facial and the lateral, here we see the pre-op pictures of the crossbite before we started, and here we see the post-op treatment, which is 9 months later. We can see where the spaces have been opened up in the premolar area. Implants can now be placed there. The crossbite has been corrected, and the case has been treated, as I say, in 9 months. The pre-op view of the patient, look at the profile and so forth, and then we see the way the patient looked when everything was healed up, a much more attractive lady. Colin Richman broadened the concept and pointed out the importance of biotype, especially in a crowded dentition. With a thin biotype, you see recession lesions and bony dehiscences, and this is predisposed for recession in the future if some osseous augmentation is not done. So osseous augmentation creates a thicker biotype. And we can see the thin biotype here, and we can see where bone has been added, and we will end up with a thick biotype. Broadening the concept. As originally presented, this was done as initial therapy. But if the patient is not responding to conventional orthodontics, then Paoo can be initiated at any time during treatment to get the case moving along. It can also be used in cases that have relapsed following conventional orthodontic treatment. These patients require a shorter treatment time, obviously, and by improving the orthodontic alignment, this enhances plaque removal. And very importantly, and you need to look this up, is the use of sodium hypochlorite in a water irrigator, which will be supervised by the caregiver. This can make a marked improvement in plaque control, and certainly this is very important in the special needs patient. So look at the website on the video, the most effective, least expensive mouthwash. Reconstruction of the mucogingival unit produces osseous regeneration. Secondly, coupled with soft tissue augmentation, creates a thicker soft tissue biotype as well as a thickened osseous biotype. What do you do in the case of a class 5 restoration, which can prevent complete root coverage? You can go in there, remove that restoration, finish it down, and coronally position the flap while the area is elevated after you have made your vertical cuts and or perforations into the bone. See the video on the coronally positioned flap for seeing this technique. Bone anchor. The bone anchor is a very efficient anchor system that is similar to a TAD but is much more effective. Since the anchor embeds deeper in the bone, it is less likely to be lost during treatment. And this is a picture of that TAD-like device, which is referred to as a bone anchor. Technique in treating periodontally involved teeth. This is an area where I think it can really make an impact, where you're having to flap an area anyway to get access to treat the periodontal defect, the osseous defect. If you're going to do orthodontics, then go ahead and do Paoo, and this makes for a very efficient and nice situation. Here we see a 42-year-old male, and you will notice that he has a nice profile. Nothing needs to be done in the anterior area, but let's look at the palatal view. It would seem this would be a simple orthodontic case. Simply remove those malposed second premolars and close the space. The problem is there are deep periodontal pockets and furcation involvements on the first premolars. So therefore, moving the second premolar into the position of a first premolar is going to be a much more involved situation. But by removing the first premolars, doing Paoo and osseous grafting there, you can see how nicely this case is going to treat out. So these are the two teeth that we're going to remove. You will notice in the lower arch, the severely tipped second molar, the third molar is in place, and that tooth is going to be removed and an implant is going to be placed there. But also I'd like for you, after this case was done, we did a lecture on the rapid orthodontic uprighting of mandibular molars prior to implant placement. And what we would do now in this case is take out the third molar, upright that second molar, and place an implant in the first molar site. And that can be prepared and the implant can be put in, as you will see in this lecture, in less than 5 months. Now we see a view of the facial which has been flapped, and a couple of things I want you to notice. First of all, there's a furcation involvement on the buccal of that first molar. And according to the MMPPI, furcation involvement is not particularly significant, not nearly as much as we thought. So that molar, even though it has a furcation involvement, has a great prognosis. The yellow line demonstrates the depth of the osseous defect on the mesial of that first premolar, and that is the reason that tooth is going to be extracted. However, there is no bone loss on the second premolar, so we're going to end up with an ideal periodontal situation when that space is closed. Here we see the palatal view where we have made a minimal flap just for access. There's no periodontal problem on the palatal. No osseous grafting needs to be done. No Paoo needs to be done. And it just shows how the technique is simplified if we just do the decortication on the facial only. The tooth has now been removed, and if you look on the right, these are the two premolars that have been removed. And if you will look at this one, which was removed in this site, we can see the severity of the bone loss on the mesial, and I think it becomes quite apparent why we elected to remove that tooth and to move the second premolar into that slot. We begin to see now where Mary Gray went in there and made the vertical cuts around the apices, and you'll also notice that she made some perforations to allow bone to be nourished by the bone oozing out of those perforations. The bone graft is being done, and I think you can visualize that this is going to create a thick osseous biotype. The gingival biotype is adequate, so no soft tissue grafting would be necessary there. Here we see the pre-op view, but look at the amazing amount of movement that took place at 2 months. Remember, we said that very little happens in the first month and you only begin to get a little movement in the second month. But because these teeth were moved into an extraction socket, the movement took place even more rapidly than normal, and we really do see a 2 months post-op on it. Here we see the post-op facial of both sides, and on the right you can see that nothing was done on that molar because it's going to be extracted and an implant placed there rather than being uprighted as we discussed earlier. On the top we see the pre-op view, the 2 month view that we discussed the slide before, and look how much the space has been closed. But then look at the 3 months post-op and look at how much more movement has taken place. And now we look at a 5-year post-op on the lower, and you can see where the implant was placed, where that molar was extracted. And we see the facial view with the space completely closed with absolute periodontal health. And the 5 month post-op view on the upper and the lower, showing how much can be accomplished with this procedure. And the view of the patient pre-op and post-op. And finally, the pre-op view, and we can see where the teeth are overlapped, and then we see the 5-year post-op where the implant has been placed on the lower, the third molar has been removed. We have an excellent periodontal result. We've talked earlier about the MMPPI, the Miller-McIntyre Periodontal Prognostic Index, and these are the things that I think are significant on this particular case. The age of the patient is over 40, so that scores a 1, not a smoker, does not have diabetes, and we're going to talk about that maxillary first molar, which is a type 1, scores a 1. The probing depth initially was a 5. The furcation involvement we discussed earlier, and we were really not particularly concerned about the mobility. The tooth scores a 5. Postoperatively, age remains the same. The molar type remains the same, but there is no probing depth. The furcation remains the same, and it scores a 3. So with a 3, we have a 96% chance of keeping the tooth in health for 15 years. With a 5, it is a 93% chance of keeping the tooth. So the prognosis is actually better than it was preoperatively. And again, the view of the patient pre and post-operatively. And I would like to compliment Dr. Zhou, who's the orthodontist that did the case, and Mary Catherine Gray. She is now Mary Catherine Lee, who is the periodontist on the case. Now let's look at another case where we're actually going to open the bite, the verb being open, and we're not going to encroach on the freeway space. On this patient, a 59-year-old female, I think you would agree has sort of a dowdy look, and look, when she smiles, she's not particularly happy with her smile, and she has sort of a tight smile. We talked about opening the vertical dimension. Basically, this lady is overclosed, and we're going to restore the vertical dimension using Paoo. And this is a very difficult and slow procedure to do with conventional orthodontics. So let's talk about the soft tissue evaluation. She has a class 2 profile. She has a retrusive chin. She has protrusive lower lip. She has a deep labial fold, and she has excess tissue under her chin. She has a deep impinging overbite because of the collapsed arches and the changes in the vertical dimension. As we look at a lateral view, she has a large overjet with dental spacing, and on one side she has a class 2 molar with an 8 millimeter overjet, and on the other side a class 2 cuspid relationship with a 6 millimeter overjet. So the occlusal view: previous extractions of the first premolars and occlusal enamel wear and drifting of the teeth are present on the left, the occlusal view of the mandibular arch. You can't tell much from the Panorex here, but here is the Panorex. On a cephalometric analysis, what do we find? A class 2 skeletal discrepancy, which is, as you know, significant orthodontic treatment. Number 2, she's got a retrusive mandible. Number 3, she's got protrusive mandibular incisors. She has a normal maxilla, and she has slight proclined maxillary incisors. So here are treatment options, from simple to complex, simple being Paoo. Option number 1, this will take in excess of 3 years. Complete orthodontics after having orthognathic surgery and mandibular advancement. Big time surgery, big time fee. Option number 2, treatment is still going to take 3 years with just conventional orthodontics, and we're going to probably end up with a compromised situation. The treatment option that the patient took was Paoo, and the treatment time was just a little over 2 years, a little longer than normal, because changing the vertical dimension and restoring that is very advanced orthodontics. So we see the pre-op view, and on the right we see 20 months post-op, and look at the significant change in overjet. The alignment of the teeth is better, and we're going to see what an impact this makes on the patient aesthetically. That's the overjet before. This is the overjet now, and you can see that probably we've increased that 3 or 4 millimeters. So this is the pre-op view, and this is a 10-month view halfway through the orthodontics, and to me that does not even look like the same lady. You notice the tight little smile she had, and now look at the smile 10 months into treatment. The profile, look at that turkey gobble under the chin. Now look at her here, much better profile, much better lip form, and that's only in 10 months into treatment. The preoperative view, the postoperative view at 20 months does not look like the same patient. And the smiling view, look how much happier that smile is than was the original smile. And now she says, people think that I've had a facelift. Only she's had orthodontics done with Paoo as the driving force on this case. And I'd like to thank Dr. Mitchell Godat, the periodontist who did the Paoo surgery on her, as well as Bill Paris, who did the orthodontics. Congratulations, guys. You did a beautiful job.